All right, surface anatomy. So we've got your posterior part here of your right upper extremity, the triceps brachii. I would focus a lot on noticing which ones are which, your lateral head, medial head, and your long head, okay? Know those. They get very confused by students. I don't know what it is. They're going to get intimidated by it or don't understand the laterality of them, which one's medial, which one's lateral. So know your surface anatomy because you're going to have to know that on physical exams and stuff like that, okay? What does the main action of the triceps do? Tricep extension, yeah, perfect. So the opposite of so an antagonist of the biceps, okay? Which is, oh, there's a bicep right there, okay? So it does the same thing here. Know where your muscles are located along the surface anatomy, okay? So you got your deltoid, your triceps brachii, your brachialis, and triceps brachii here, part of it. Create this nice divot in between there. There's a nice vessel through there as well. And your biceps brachii. Shoulder movement. So last year I had you all get up and dance and do stuff, but we're tired. I can do that again. You guys want to do it again? No. Thanks. I knew it. I'm like exhausted. We'll come back to it when we're all refreshed next week or tomorrow, right? Right. But yeah, so forward flexion, extension, abduction, adduction, internal rotation, external rotation. So this is basically all those motions we just discussed in the previous PowerPoint in a nice little slide for you guys here to see it, okay? So arm muscles, when I say arm, I'm meaning the entire upper extremity. Remember categorizing things, so which ones do what action? There's extension and flexion, so in your entire arm, how many extensions do we have and what muscle is it? Yes, one, and then the triceps brachii. And then three flexors, your biceps brachii, brachialis, and coracoid brachialis, okay? Remember I was helping you all dissect those arm muscles in lab. Some are superficial, some are deep, some are intimate to the humerus, some are intermediate. You need to know that, okay? But that's a good way to get you started. But I've been telling you this in the past 20 minutes. Know your actions first, okay? How many of you think that'll help you guys? Good. Know your actions first. Don't study origin, insertion, no. Action. Oh, there's the origin. No, there's, that makes sense, okay? Right? You guys, trust me, it'll cut your time off in miraculously, okay? So movements of the form. So when I say form, I'm talking about this or this. Yeah, this part down here, okay? Your antebrachium, that part. Flexion, extension, supination, and pronation. So that is what is basically happening here. Your anterior groups are, as I mentioned, a couple PowerPoints going over. Anterior group is your wrist flexors. Dorsal side is your wrist extensors, okay? All right, so primarily at the elbow joint, so flexion, extension, supination, and pronation occurs at the forearm, not the wrist, okay? I'll write that down. That gets confused a lot as well. And basically, these guys do almost everything at the elbow joint, okay? Yes. What did I say? Sorry. Pronation and supination occurs proximally here at the forearm. They're like in between, they're in the interosseous part of the radius and ulnar, so that's why they do that. So a lot of people I've seen in my teaching career have thought, oh, it's wrist pronation and supination. No, it's forearm pronation and forearm supination. So always name the body part or the region before the action, okay? So if I say elbow flexion, I don't just say flexion. Flexion of what? Right? You're confused. So shoulder flexion, elbow flexion, wrist flexion. So you got to name the joint or the region. Okay, sounds good. All right. So this is an excellent. If you want to like literally divide all your muscles like that, count which ones, how many do what action in that particular region. Divide up anterior compartment, posterior, stuff like that. You'll be able to break it down better. Okay. Or not. It's up to you. Okay. I already know this. Okay, I'll stop. I'm sorry. All right, so elbow motion here, deflection, and then elbow or forearm, so supination pronation. Okay, so there's that. What's if I'm doing this? What's this? Supination. And I taste the soup and I don't like it, so I pronate it. I throw it down on the ground. Okay, that's one way to remember. Okay, y'all heard me say that before. It's bad soup. You pronate it. Throw it on the floor. Okay, so flexion extension occurs through the trochlea. Y'all remember what the trochlea is? The distal humerus, that part. Okay, know which bones articulate there as well. Okay, if y'all were building your Lego set downstairs with the bones in the lab, you'll understand that better. Okay, and then we'll go from there. So know which ones flex, which ones extend. Your coneus muscle as well. It's all in there. I can't see it very well, but it's all in there. Pronation, supination through the capitulum of the humerus. Okay, so notice that they're in red. So what do you guys think? You should know that? Yeah, probably. It's important. And pronator teres, supinators, and so for those of you that train, when you're doing a dumbbell curl for your biceps, we start here and then we kind of literally supinate a little bit to get that little extra edge there. Because if you start with the neutral grip on your side and you flex it, you're still supinating. So your biceps are a bit of a supinator as well. Okay, unless if you take out, you just have the dumbbell in your hand, you let your wrist like extend, don't flex it or stabilize. Your forearm muscles, which act as synergists to the biceps, are taken out of the equation. So now you have more training, more emphasis on the biceps. If you hold the dumbbell like this, you're just focusing on the biceps. But here I'm not doing any supination. But if I'm starting from a neutral grip at my side, I'm doing this like a regular bicep curl. Notice I'm supinating as it comes up. Okay. All right. Sounds good. All right, so and know these definitely. You all should have an idea of where these are located and what they do and how important they are. Okay, I'm not going to waste more time on that. You've kind of really emphasized the median ulnar. Anytime you finish your notes, do y'all do your note test there today? Was that fun for you guys? Yeah, so so anytime you finish upper extremity exam, always say radial ulnar median musculocutaneous nerve are intact, sensory motor function, all that stuff. You gotta include all that. Okay, so that we know what we're talking about. But know where they're located and know what they do. But yeah, so this is primarily their motions here. For flexion, so the muscles the nerves that help with that. Okay, extension, radial nerve, pronation, median nerve, supination, musculocutaneous nerve. For the biceps brachii, I just told you guys, and radial nerve for the supinator muscle. So I would definitely put a big circle around this one. Okay, know what nerves cause what movements at the forearm. That's what I just wanted. So I just want to get the first 10 slides out of the way. So we'll reconvene tomorrow. We'll finish this, and then we'll start lower extremity part 1. Okay. Any questions, comments, concerns? Come see me. It's bedtime. Okay, and we're on. So we have a model downstairs in the anatomy lab similar to this one. Notice that you've got several layers of muscle there. Okay, you got superficial, intermediate, and deep layers. Okay, by just looking at this in the brachium, your arm there, is biceps brachii in the superior layer compared to brachialis. Yes. Okay, yeah, so you divide it like that as well, which muscles are in the superior aspect, which ones are in a deeper one, because these models do fall apart, not fall apart, they break them apart And some of you were like coming to me with muscles in your hands and the arm in the other, like some horror movie. Look what I found. But anyways, it's like deltoids in your right hand, the rest of the arms in the other one. So these things come apart. You can play with them. And those important nerves right down the center here. Okay, those are very important to know. Your radial nerves coming through there, and then the meaty part there inferiorly. What's that one called? Triceps. Yeah, it's listed right there. Yeah. That was not a trick question. But yeah, so yeah, it's you're gonna have your biceps create a nice fold here, triceps here, and then down the center here is your nervous structures and venous structures right through here. Okay. Now we'll get deeper into this lecture today, where there's gonna be a section on the veins and arteries. I need you to know that. Why? Because we'll be sticking IVs in these things. You know which ones you're putting stuff into, right? It's kind of important. You guys to know those. Okay. All right, so this model is excellent to study off of. The anatomage as well. Those two arrows are pointing directly at the biceps brachii. Brachialis. So he looks a little different than your biceps brachii. Okay, so he's very intimate to the humerus. What I mean by that, he's like directly on it, like comes right off of it, the distal half. So if you're going to divide up the humerus into thirds or halves, like proximal third, middle third, distal third, in this part, he's going to be incorporating the middle third and distal third of your humerus. That's his origin, that's his anchor, and he inserts in the coronoid process of your ulna, which is that little like skateboard ramp thing I talked about last time that can break during an elbow dislocation. And its main action is to flex the form at the elbow. So basically, elbow flexion, which is similar to the biceps muscle, which is the same thing. Okay, so if you're lifting weights, you're lifting your drink or Stanley cup like this, if you want, think about biceps brachii and brachialis are helping me drink out of my cup today. Okay, all right, sounds good. All right, so if you know your bony attachments, you'll know where things are pulling on and when things are anchored. Okay, that's the whole point of this thing, to do that as well. Okay, so here's a brachialis. He's just inferior to the biceps brachii, and that's the distal third of the humerus there. See where it's located there? Get my little so right here. Okay, here's your entire biceps, and then from like middle third to distal third is a brachialis directly underneath it. Okay, there he is again. So the coronoid process, remember him? He looks like a little skateboard ramp, like a half moon. So he inserts right there. So his anchor is in the actual humerus. So when he contracts, he's pulling up on that coronoid to bring your forearm up. Okay, it's kind of like a little drawbridge. Okay, so anterior aspect of your arm, the coracobrachialis. So you see him up here. It's in the name, basically. Coracoid process, it's where it originates from, and it inserts along the humerus. Okay, medial aspect there. Okay, so what does it do? It flexes and adducts. So when we think of the insertion here along the medial aspect of the humerus, and we corroborate that with the action of adduction, does that make sense why it's on the medial aspect of the humerus? Okay, so start thinking like that. Okay, so if it's there, it adducts your arm and also helps to actually, I don't know if you guys can write with little fancy pens on here where it says action. So when it says flexus the arm, I'm meaning like forward flexion of the shoulder. Okay, so you can see how that's happening. Coracobrachialis is responsible for forward flexion and then adduction this way. Okay, that makes sense how it's positioned now. Okay, so I gotta make a note on that one too. And your famous musculocutaneous nerve. Okay, I thought that was funny. Okay, so triceps brachii. So, all right. So a lot of students get hung up on the long head, lateral head, and medial head. Okay, literally, you have to inspect this thing in the diagrams as well as the models downstairs. Visualize them. If there's someone in here that has like really fit arms, they can do this. You can study off of them. Mine's covered in tattoos, so not really that. You can see that one, but anyways, but literally, like I get one of those pens, and when I was a student here, I'd trace the triceps and label them on my partners. That way I could visualize where they are, because you're gonna get confused. And you gotta understand these things, okay? So that's why I put little underlines under them. So one originates from the scapula, posterior humerus, posterior humerus. So 2 out of 3 originate from the posterior humerus, and that's where the muscle's located. And your olecranon process, which is this pointy thing right here, that you all saw in the lab with the ulnar bone, that's where it inserts. So when it contracts, it's able to lift your forearm posteriorly, causing elbow extension, okay? You can actually put your arm back here and do this. You can actually feel them contracting, okay? Yeah, hit your partner. But yeah, and then the radial nerve, okay? You know where it's coming out of, all right? So it takes a little bit of like time and practice, motion, do the motions with yourself. What's that? It's over. The machines have taken over. Skynet. Remember I seen Terminator? Skynet is the right thing. Alright, so I'm scared to speak now. I'll just let it talk. Anyway, so you read my mind. Triceps brachii. So extends the form at the elbow, basically this motion here. Okay. Don't worry. This can get a little bit confusing here. So main action here is for triceps extension here, elbow extension. Okay. I'm not gonna get too in depth with the other stuff. That's for orthopedic surgery. So yeah. So here's right here. Encompasses the medial side and then the posterior part of your humerus. Okay. And there he is. Oh, one other thing, I want to remind you guys that, I know I told you guys this for test 1. When you see diagrams in the exam and there's like little like lines pointing and the words got erased, because that's how I have to do it, look for these big like green or blue arrows. I don't know what color it is, because I noticed that when I do the exam, it's like this shade of color, but when it pops up on your stuff, it's like blue or something. Because I have the accommodations for my site here. That's the arrows I'm talking about, okay? Not the lines that may be pointing to other structures, so I don't want you guys to get confused, okay? So there'll be like a big arrow, that's the one. It'll say, what is the structure depicted by the arrow? The arrow, not the lines, okay? Because I can't, sometimes I can't edit these things completely, so, all right, that makes sense to you guys? You guys know what I'm talking about, right? You've seen them? Yeah. I just don't want you guys to get confused. So. All right, so Anconius. So he's over here. He's a little guy. He's short. Kind of comes out of a 45-degree angle. So he's a little helper. He's Anconius, a little helper. He helps out the triceps, extend out the form, provides some synergistic qualities to the elbow joint when it's in motion, and it also helps with pronation. So when we pronate, it's doing this, okay? So those are 3 little guys. He's more of a synergistic muscle and also helps with pronation. But he's right out here. You can actually, like, if you're fit, you can actually grab a chunk of him right here, right there. But yeah, he's well demarcated in the lab models downstairs as well. So no OIAs for this guy, as well as innervation, right? And then this is what I was talking about a few slides ago. Do you see where I'm coming from? Wouldn't it be wise to know these if you're going to be sticking needles and IVs in people? Yeah. So you know where all these things are located, right? And sometimes the nurses, they use the terms that person has good veins. People who have nice prominent veins that don't collapse, who have poor veins, they collapse easily. Like if you put a needle in some veins and they just literally like flatten out like a balloon, they have to get another one. So it's hard for them to find them. So there's certain techniques that I learned best from the nurses when I was on rotation with my IVs. Like they do them all the time, and I'm like, hey, can I watch? Most of them were like, cool, yeah, just watch. Someone let me do it, but yeah, they have little nuances and stuff. So you guys on rotation, literally like tag along with the nurses and ask them, hey, do you have any nuances? And just write it down. Like, well, what I mean by nuances is like little caveats, like little techniques that they've just picked up on. Oh, we do this, this happens. You know, everybody has it with experience. Even you guys in 10 years will have nuances to certain things, whatever you're specializing in. But yeah, these are very important to know where they're located. Don't sleep on that. And also the veins as well, okay? More important ones that are in red here, cephalic and basilic veins as well. Those are categorized as superficial, and then we have deeper veins. They kind of create like little highways and merge with each other. So understand where those are located as well, okay? That's basically like we've been doing all semester, blocking all these words out and testing yourself with mixing, matching the numbers, okay? Or I know we have like when you guys start doing venipuncture in the summer next year, we have these like fake arms that you can actually like inject them and stuff comes out of them. So make sure you have your goggles on that day. You guys might not be as good as you think you are, and it sprays everywhere. So these are high pressure arteries. So okay, also lymphatic drainage. We need to know this as well. Epitrochlear, lateral axillary node, central, and intraocular. You guys have been like taught this in 3 or 4 classes already, right? My class, PD, know the importance. I know it's like nodes, but if you find any of this stuff backed up and swelling up, it could signify something very tragic for the patient. Okay, so that is why it's important, and you need to know that, right? So here. All right, so clinical significance. So there's a lot of stuff going on at the elbows. There's ulnar arteries, there's radial arteries, brachial artery, there's your radial ulnar median nerve distribution. So when there is a distal humerus fracture, those shards or fragments of bone can also sever an artery or a nerve. I've seen it happen, and I'm not sure if I told you this story once. There was a MMA fighter who got picked up and dropped, but our autonomic reaction, we're about to fall, is to put our hand out like this. And he did that, and he broke his distal humerus and severed his median nerve. So he had something they call an ape hand. It literally looks like this, and he was stuck like that. I'm not sure if he ever got the function back, but he severed his median nerve, and I think he was permanently stuck like this. It literally like causes this hand to look like that. That's just the clinical significance of this. So it's very intimate to the area that breaks. You cut one of those nerves, you're pretty much in a lot of trouble. Okay, and the thing is, you got injured by the papers. Yes, newspapers. Back then, newspapers. Yeah. I'll show you what newspaper is later. But he said, "Oh, I want to fight again." I'm like, dude, come on, man. Just focus on learning how to grab a fork or a spoon now, man, because it's gonna be hard to come back from that. But yeah. So anyone along that line can affect the vessels, arteries, veins, or the nerves. So very important. You don't miss that. If you see it on an X-ray, check pulses, check nerve function, sensory and motor distribution. In this particular slide, I would focus on quite a great deal. Median radial ulnar distribution, know where they're located. You see where they're marked right there? I'd blank out those words, median nerve, radial nerve, and put numbers by it and know which way they're oriented, okay? Notice that the ulnar nerve is in this area called the ulnar notch. It goes, this is your medial epicondyle of your distal humerus right here. It goes posterior to that, okay? It doesn't go on top. You can actually like touch it right here. There's your ulnar nerve right here. That's your ulnar notch. They call it the funny bone, or when you hit yourself there and you get that horrible pain here. And they say, oh, that's not very humorous. Dad joke. Joking. You're supposed to laugh now. Make me feel better. Huh? Yes, thank you. I feel better now. All right. All right. I know. I'm being dumb. All right. So yeah. So this is what I was talking about earlier. Brachial plexus, your little friend there, and then he branches out into the peripheral nerves. Axillary nerve is going to your axilla, as you can see here, your armpit nerve. Radial nerve literally will traverse through all this stuff here. Musculocutaneous nerve is right there. Median nerve is literally going straight down here and bifurcate here into the carpal tunnel here, as you all know. Median nerve is the carpal tunnel, that's where it houses, okay? That's the nerve affected by carpal tunnel syndrome. But yeah, know these structures well enough. Looks like a little circuit board here. So ulnar, median, radial, ulnar. You notice a theme here, right? The important nerves I want you to know. Anybody notice that? So what do you guys think? Might want to know it. Okay. All right, so this guy here, median nerve. So when we say anterior compartment of the forearm, I mean the entire, from the start of your proximal radius and ulna down to your distal radius and ulna. That's your anterior forearm right here. Anterior forearm, not posterior, not dorsal. Anterior, ventral, same thing. Okay, so he's going to innervate the majority of your wrist flexors. These are extrinsic muscles. Forearm muscles are extrinsic to the wrist. They contract up here and move the wrist. Remember I told you guys which muscles are in the anterior forearm compartment? Flexors, perfect. And dorsal compartment? Extensors. Okay, so basically majority of them, except for a couple of them, the median nerve is going to be responsible for wrist flexion. Okay. So the motor part of your median nerve is for wrist flexion. So all your flexors except, flexor carpi ulnaris, majority of them are innervated by the median nerve. Ulnar nerve also is not the chief nerve for the anterior compartment, but it does some of the muscles there. So the ones that the median nerve doesn't cover, look, the ulnar nerve will cover. Okay, flexor carpi ulnaris, and our half of the flexor digitorum profundus. Okay, so flexor digitorum profundus is the muscle that is going to flex your digits. But profundus, what does that mean? Deep. So it's going to be not at your proximal phalanx, it's going to be your distal phalanx insertion. So he's going to flex your DIP joint. Flexor digitorum superficialis stops at your middle phalanx. Okay. So he's going to only be responsible for flexing the PIP joint. That makes sense? So profundo's deeper, more distal, flexing your fingertips basically, and then flexor digitorum superficialis, middle phalanx doing this, okay? All right. And your radial nerve, basically that's going to be your wrist extensor. Remember Saturday night palsy? The guy's hanging out like this, on a Saturday night and basically stops his radial nerve from working. Or the example I gave you earlier where I had a patient that dropped the washing machine lid on her forearm here, and she came in like this to see me. I can't bend my wrist. I can't do this anymore. So I had to construct a fabricated dynamic splint to keep her this way, and every week I would change the degrees on it to keep her moving. It took about almost 3 months for her wrist extension to come back. And I started on occupational therapy, but yeah. So just know where those are located, and you should be fine. No, it's a lot of material, but literally, because yeah, cerebral palsy, crutch palsy, also you get from crutches. That's why they put you see people with towels and pillows underneath their crutches, so that's just there. But so basically, you got to support your weight with your hands. Basically, you do it in your shoulders, you're gonna get an inability to do that. I've had a bunch of mid-humeral fractures come in as well in the ER. Actually, like had to stop a actual doctor. He consults me when I get there to the ER. He has a patient holding a 15-pound dumbbell, and the patient was laying prone on the bed, hanging out to the side. And his theory was to keep the fracture elongated to prevent the nerve from getting damaged. But in essence, the nerve was trapped in the fracture, and he's actually pulling on the nerve and basically causing more compromise to it. So, yeah, as a PA, it's okay to raise your voice at a doctor sometimes. That was one of my times. I said, "What in the nice word you're doing, sir?" Yeah, it wasn't, sir. I was not happy. It was like late at night, and I walk in to see that thing. Yeah, it basically led us to more hours in surgery trying to get this guy's nerve to get out of that bony part. And I don't even think he got full function of his wrist extension again. So I don't know. Just don't, guys. Point of the story is, if there's a mid-humerus fracture, don't lay him down or somebody have him holding a weight. I don't understand that. It's pulling a lot of traction on the nerve, and this is what's going to be the problem here, okay? So if you lose wrist extension, you're going to be limited in a lot of things, okay? So let's take a 5 to 7 minute break before I'm going to cubital fossa. That's kind of very detailed there, okay? And we'll go from there, right? You guys okay after farm? You guys seem like... All right, so 5 to 7 minutes, we'll come back and we'll hang out. Okay, we were back on cubital fossa. So I would get familiar with your borders, kind of like we've been doing all semester. What muscles are superiorly located, medial, and laterally, and what makes up the cubital fossa. It's like a little triangle. So basically right here, and that's where your big artery is right there, a little space there. Since it encompasses part of your antebrachium, your forearm, they also call it the antecubital fossa. Okay, that's where most of your venous procedures are done there. But I need you to understand that superiorly, you're going to create a little alignment, a little dotted line between your medial and lateral epicondyles of your distal humerus. That's going to be the superior border. Medially, your pronator teres is marked right in there. Right here, see that little guy right there? That's pronator teres. And then laterally, your brachioradialis, which is a large muscle here. Anyone does hammer curls in the gym at all? You know what I'm talking about? Yeah, these. So that one's going to target specifically your brachioradialis, like big time. It's literally doing this, okay? Or if you have a stein, like in the Oktoberfest, y'all know what those steins are? Those huge, like, like that. You say, oh yeah, I'm drinking beer. But yeah, Oktoberfest. There's a lot of Oktoberfest festivities here in the fall in Orlando, so if y'all want to go, you should go. In between tests, just go get great German food and steins. All right, and then the floor, el piso, is your brachialis and supinator muscles, okay? So big circle around this guy, know your borders, know what you're looking at, because if you're asked to put in an IV, I need you to know that you're not sticking it into the pronator teres, you're actually hitting them, okay? Because I've had that happen before where they miss the vein and you get this big bolus of superficial fluid accumulation in one of the compartments, and then that leads to compartment syndrome. We have to take them to the OR later that night. So know what your landmarks are, okay, guys? The reason I teach these things is so bad things like that don't happen. I've seen a lot, and it's not fun having to fix something that shouldn't have happened if the person knew what they were doing, okay? So here are your contents of your cubital fossa. Radial ulnar arteries, biceps brachii tendon, median nerve, radial nerve, medial cubital vein. So these are very important structures to know. Your brachial artery is literally the main guy right there. I don't know. Does anyone have a prominent brachial artery right here? You might want to check, or do they have flat? You guys, okay, cool. I got one here. Yeah, when I was in the hospital, everyone was like, "Oh, we love your veins." I'm like, I don't like being here. This sucks. Been here 3 weeks. Sucks. Anyways, but yeah, the nurses are like, got excited. Oh, phew, easy to take blood. I did take my blood at 4 a.m. every morning. You know, so by 7 a.m. when the doctors showed around, it was ready for them. So, but yeah, they like the plump, juicy brachial artery right here. Okay. All right. So yeah. So it's been said. There you know that brachial artery. This is where these are the main guys in your form. So if you after you work out and you get this condition called reactive hyperemia, that's when your veins and arteries engorge with blood after you're working out. So that's the ideal time to study the slide. Okay. So go downstairs, lift some weights, wait for reactive hyperemia. Have your buddy take a picture, and you can study. There it is. That's what he was talking about. So yeah. So how you actually see them. You get all a good pump going. All right. There. I shared a way to study for this one. But yeah. Important to know all your foreign vasculature. Same thing here. Obviously, they're parallel to each other. Navel, remember that stuff. So from there. Wrist movements. Y'all remember these? So flexion is like, come here. Extension's like, no quiero, stop. No más. It's like, Professor Perez, no más lecture, stop. And then radial deviation. I don't know. Maybe we should have a break or not. Okay? Y'all got that? All right. Okay. So wrist extension, flexion, radial artery deviation. All right. So those are wrist motions there. I'm no longer able to demonstrate that on my left wrist. I can do this. That's it. That's about how much range I have. I'll stop. Doing the robot. All right. Whoa, look at this. This is a study slide. Put some numbers by this and blank out all the words and make a key. And do that, okay? You need to know these. What's that? Yeah, no, they're important. The forearms. No one likes the forearms. Why is that? We have some on the other arm as well. So same thing. Oh yeah, there's a posterior compartment too. Look at that. Same thing. Study slide here. Create one to put numbers by and try to test yourself on it. Okay. Ooh, what's that? That's fancy. Skynet again, trying to take over. All right, so radiocarpal joint. What do I mean by that? So remember we have the radius meeting the proximal carpal row. Remember that? That's the radiocarpal joint. So actually, like, put your finger right here, track down your radius. It's a little space here. That's your radiocarpal joint. Okay, remember the ulna does not articulate with any of the carpal bones. There's like a little disc there called TFCC. We'll go over that later. But radiocarpal joint is basically your scaphoid lunate articulating with the radius. Okay. Ulnar carpal joint also over here, but it does not articulate, but it does create a joint as well as there. Flexion extension. Okay. Flexion extension. All right, prime flexors, yeah, just kind of, it's a lot, right? Flexicarpi radialis, flexicarpi ulnaris are your main ones for flexion extension of the wrist. So write those down I just mentioned. for flexion, excuse me. Flexor carpi ulnaris, flexor carpi radialis, okay? The other ones, palmaris longus, most people don't have that muscle, some do. Make sure if you do this, like if you do this, you can actually see your palmaris longus. Palmaris longus, you can actually like right here, one right here. If you make a fist and do that. We use that as a graft a lot of the time in hand surgery. Some people it's missing. Everyone has one here. Okay, cool. Yeah. All right. And then, so on the extensor side, the dorsal side. All right, guys. I'm going to say some key intel right now, so you might want to pay attention. Extensor carpi radialis longus, extensor carpi radialis brevis. These are abbreviated. If you don't want to say all that, I know it's a lot, you can just say ECRL and ECRB. The ECRB is the Professor Perez muscle. That's the one that got removed from my forearm to be used as a tendon graft, so you want to remember that. If y'all want to see in the lab, I'll show you where it actually is located. I have a scar right here where it was, where they went in there, cut open and pulled it out. So, literally right here. So, I got a big, when I do finger extension, there's a big divot right there where it was. So yeah. I'll show you guys in the lab, okay? So you guys can have a better understanding. But ECRL, ECRB are your prime extensors, okay? The other one, extensor digitorum, flexor digitorum, those are for your digits. We'll go over those later, but primarily the prime ones, the big ones there are flexor FCU and FCR for flexors, and ECRL, ECRB, okay? Just to make it feel better. That makes sense? So 2 for each one. And just use your like abbreviations, like KFC. What else is there? ABC liquor, there's all that stuff. Okay. All right, so, oh my God, look at all this stuff. Yeah, so it's just showing your superficial, intermediate, and deep groups. So I need you guys to categorize. Are those hands up in here? Yeah. There's 3, right? Am I correct? Okay. Oh, sorry. Okay.
You have the abbreviations, or will you have them written out?
I'll have it written out.
Okay.
But I'm just trying to like make it easier for you guys right now.
Okay.
And also for me, saying all those words together, I kind of start mumbling at the end, and you guys can't understand me. So it's not fair to you guys, but yeah, it's just a cool way to like learn it. You know?
Okay.
Like so, KFC. What does that stand for? So you know it stands for Kentucky Fried Chicken, but you say KFC, right? So ECRB, what's that one? Extensor carpi radialis brevis, and who doesn't have one in their left arm? Okay, there. All right. But yeah, there's superficial, intermediate, and deep groups. I need you guys to make 3 columns of those. I think I did that for you guys in your workbook, not sure, but that'll help you kind of understand which ones are seen. Some will be removed, and you'll see the intermediate layer and the deep layers closest to the bones, okay? Yeah. There are some caveats here. So your brachioradialis, if you guys were to do this motion here, like and hold it, you can actually feel your brachioradialis. And it's right here, this big one right here. Okay. So notice it's actually like doing flexion, but it's on the extensor side, the dorsal side. So that's one caveat there. Okay. Just remind yourself of that. Okay.
So what's the caveat?
Brachioradialis originates from the lateral epicondyle, and it's flexing the wrist. See that? In this position here. But that's just a caveat. I'm not going to test you on that, okay? Just to kind of be aware of that for your future careers. But that makes sense? Okay. All right. Because I don't want to confuse you guys. We'll talk about that whoever teaches ortho, spring semester. All right, so anterior volar, your flexor compartment, remember I told you that, pulmonaris longus. So flexors come out of your medial epicondyle, extensors come out of your lateral epicondyle. Okay, just that's basic standardization right now for your stage in your PA school career right now. So obviously, flexors the wrist and innervated by the median nerve. Okay, remember median nerve is a prime innervator of your wrist flexors, except for your flexor carpial nerves, your FCU. So, and the FCU is innervated by the ulnaris. Okay. All right. So, no difference between those two. So it's basically, if you know which side the muscle's on for the most part, you'll know that the action already, flexor or extensor. Okay. Volar anterior compartment, posterior compartment, dorsal compartment. Dorsal compartment are your extensors, anterior are your flexors. That's when you guys say the word flexors. Let's try it again. Dorsal side, extensors. Volar side, flexors. Okay. Okay. It's just a bunch of muscles. They do basically the same thing, but you have to know where they are, how to differentiate with them, and all that good stuff. Okay. So pronator teres. Okay. So this guy is basically going to pronate your forearm. Okay. So what is this pronation or is this pronation? And how are we going to remember that? You pour your soup on the ground because it tastes horrible. Okay. All right. Pronator teres, the origin, humeral head, the medial epicondyle, basically. It's a lot of stuff there, but distal humerus region there. Oh my God. Yeah, this is a lot of stuff for you guys. What do you guys think?
Yes.
Yeah.
So take it out?
Oh, no. We're going to keep it. But I'm just trying to think of a way to, because I just mentioned, your flexors are on your anterior compartment. Pronator is in the name. This one's, I would suggest knowing where it's located on the diagrams to help you visualize what it's doing for this one particular. So there's just so much origin on this one. It's confusing. So just look at the diagram where it is. It's showing it on there, right? Yeah. So look at it. You can isolate it. The Netter's book downstairs actually does a good job of isolating it. Also in Anatomage, you can just type in pronator teres, and that's the only thing that will show up. But just to visualize this muscle and see what it's doing, how it's pronating, because it's literally rotating that radial head over the ulna. Yeah.
So know the action.
Yeah, so the action, and I think that'll help you guys understand where the origin is and the insertion. Okay. Sounds good. Yeah. Pronation. Any more questions? Yes. Mm-hmm. Yeah, but by knowing the action and visualizing where the muscle is on the diagram, the origin is just going to come. You know what I'm saying? It's just going to fill into your head. So I don't want you to spend time like memorizing humeral head. Okay, basically, if you can see where it's coming from, you'll be fine. You'll have the answer in front of you. There's 4 choices, right? The answer's in front of you, correct? You have to pick the one. So I'm not gonna like be that minutiae, okay? You know, I'm not like that, right? I haven't been like that, right? Okay, so it'll be fine.
So you're not gonna ask that.
I probably won't ask that. I'll probably ask action.
It's okay. You could just be transparent with us.
But then I won't be here anymore. They'll get someone else in here.
Well, right, good.
They'll get the guy I had when I was here. Read your book. Shut up. All right, so flexor carpi radialis. So this guy. So all right, so here's what I want you to know about this guy. So highlight medial epicondyle. Put a big yellow highlighter there. And this one, your second and third metacarpal base, okay? Obviously, it's in the name, right? Flexor, so don't worry about knowing the action, but this one in particular is different because it inserts at the base of the second and third metacarpals, which is basically, you know, your metacarpals that we just discussed the other day, okay? Sounds fine? I'm trying to make this easier for you guys. There's a lot of verbiage on here. Everyone okay? No, yes, no, following. Okay. Y'all are glistening. Are you guys hot?
Yes.
Do you want to open the back door? Is there a doorstop still back there? Or someone stowed it? Okay.
As you take. And then you will go.
All right, this one, I'm primarily concerned with the insertion, okay? I think I said you guys, so flexor torn superficialis, the insertion is basically the middle phalanx, okay? So your middle guy right here. Don't worry about the origin, that's a lot of verbiage. Doing you guys a solid right now, okay? So I'm more concerned with insertion because that's what's going to be pulling on, causing the action, okay? Because if someone has a torn flexor digitorum superficialis tendon, they will not be able to do this anymore, okay? It'll basically be stuck like that. Okay? Flexor, the only one that will be able to flex is the DIP. You understand? So that one's the profundus. So everyone grab your hand like this. Your middle phalanx, that's the one right here. That's where your FDS, your flexor digitorum superficialis, inserts on the volar side. Okay, right here, each one of them. 2, 3, 4, and 5. Okay, middle phalanx, and it does flexion of that. So what joint is being moved right now? PIP joint, proximal interphalangeal joint. So if you're saying bye-bye, that's your flexor digitorum superficialis, FDS, middle phalanx, inserts. Okay, everybody got that? FDS, middle phalanx, 2 through 5, so long, okay? Now, go to the next one. Flexor digitorum profundus, okay? Now everyone, same thing, put your hand like this in front of you. Now grab the volar side. That's your tuft, your distal phalanx. This is where the FDP, profundus, deeper, it's more distal. That's where it inserts. Each one of them, okay? Now that one's going, not too many people can isolate DIP flexion. I can slightly on my index, but that's what's going to basically flex your DIP joints, the tips of your fingers. Okay, so FDP, distal phalanx flexion, FDS, middle phalanx, okay? That's what I want you to know between these two muscles, okay? Because it's important for hand exams. You know which tendon's torn, which motion can't be done, which action can't be done, and so on and so forth. Not so much the. Is that a hand? Yeah. Yes.
So my grandma can't flex her middle finger at all.
At what joint? Like all of it? Like. Yeah, she probably has DIP joint arthritis and PIP joint arthritis, and the tendon's probably like withered down in a way. So, yeah, that's what happens. Yeah.
Can you just say what you said, FDP and then FDS?
Yeah. Yeah. Okay. So, all right, everyone, pay attention. Let's focus. All right. So, just like KFC, we're going to call this one FDS, the first one, superficialis. So, superficialis, he's superficial, and he's short. Okay. So he's going to stop at the middle phalanx right here. Okay. This is your middle part, just right here, the front of it. Okay. Everyone keep doing that. Middle phalanx, your FDS inserts right here. Okay. Now, when the muscle in the forearm contracts, it's going to pull all those tendons to do this. You see that? at this joint, your PIP joint. You got your knuckles and the next joint. That's the next joint. That's your PIP joint that flexes, okay? So FDS is doing that. Okay, now we're going to go to flexor ditorum profundus, which is deeper or more distant. Distant meaning distal phalanx, your tips of your fingers. Now he's going to insert right here. Now he's even responsible for flexing the distal interphalangeal joint, the DIP joint, your fingertip. So not too much motion, but it's basically doing this, okay? And can anyone do that right effectively? How many people cannot flex their DIP joints? Yeah, it's not much motion, but it does happen. But yeah, so that's your FDP, okay? So everyone, does that make sense? Maya, everyone? Good.
Sorry, can you repeat? You don't have to know the origins?
No, don't worry about the origin. Just know that the muscle's in the forearm. It's an extrinsic muscle that acts onto the hand and does those motions, okay? FDS, FDP. But know what it looks like so you have an understanding of what's going on. But I'm primarily concerned with the insertion of this muscle because for hand exams, you need to be able to differentiate between the two. So one way we test it is, could I have a volunteer, just someone come up here real quick? Anybody? Just one person. Come to you. All right. So, Jimmy, you want to turn the lights on real quick? Sorry, everyone close your eyes. All right. So when I'm evaluating someone's hand, I have them. Okay, keep your finger right there. Resist me, and I'm grabbing the middle phalanx. You can relax this one. I do that. I'm testing her FDS tendon. I go through each finger. Do that. Sorry, not hers. Her one finger like blew my left hand off. Nothing. So yeah, she's very strong. And then you test the FDP tendon right here by resisting. So I'm pulling this way and she's going the other way. Obviously she's winning. But yes, that's how I test them, okay? And if I do this and this happens, like she can't flex it, then it's probably torn, okay? Or your kids like your grandma, she's probably stuck like that, okay? But yeah, that's how I test them. When there's a laceration in the hand, like in knife fights in Chicago, I used to see a lot of these, like they do a defensive wound, they grab the knife and they sever like their FDS tendon. So they could only move their DIP joints. I do this and it'd be like nothing. Okay, does that help you guys out a little bit more? Okay. Jimmy, okay. So that's why it's important to know these two, okay? Knife fights, right? All right. All right, so, so there's abduction and adduction of the wrist. Remember your radial deviation, ulnar deviation. These guys, so you'll notice that all these have the term radialis in their name, except for the pollicis, your thumb. So everything's on the radial side that's going to abduct, okay? You see that? Your thumb, your pollicis muscles is going to be an abductor. Abductor, remember you're in anatomic position, correct? Midline's down here, so I'm abducting. I'm going away from it. This is what's happening. So all the muscles I'm going to do are going to have the term radialis in them. Kind of just make a list of those, and then pollicis meaning thumb. So you're on your thumb side, which is your radius, your radio antenna. Remember that. Adductors are going to be the term ulnaris in it, so it's going to basically move towards the ulna and adding to the midline, okay? So that should help you guys understand this better, okay? I'm trying to help you guys kind of study for this, so if you do see choices on there. So flexion, extension, radial, and R deviation are the motions that we're focused on right now with the forearms. Extensor supinator muscles, so these muscles extend, abduct. All right, so this is a lot of minutia. So the thumb primarily I'm concerned with on this slide. So we have our hand out like this, anatomic position. So when I extend the thumb, Thumb extension is basically, I gave myself a thumbs up, okay? Thumbs up is thumb extension, okay? Thumb abduction, remember I'm in anatonic position, so is my thumb going this way? That's abduction, away from my midline, okay? Does that make sense, everybody?
So what's extension
A thumbs up.
and flexion?
Flexion is this, I haven't gone over that yet, but. So I'm here, midline's here, so abduction is going away from the midline, correct? So my thumb is going away from the midline, do you see it? It's going in this plane. But when I'm doing extension, I'm going backwards, thumbs up. Okay, so extension's like a thumbs up, like great job everyone. That's a nice thumb extension, okay? Abduction is going away from the midline in anatonic position. Extension of the medial 4 digits. So extensor digitorum is basically going to extend all 4 of them. Extension, basically, this is extension, going from flexion. So the opposite of bye-bye is reverse. Extensor removes that. Extensor indicis is your index finger, okay? So he extends your, and digiti minimi is your small finger, okay? So this is gonna be easy to remember. Digiti minimi is your, this is extensor digiti minimi. It's extending the smallest finger. Extend your indicis, extending your index finger. Extensor digitorum, extending all 4 of your digits, okay? All right, so ECRL, ECRB, and ECRE. So I think we've gone over those already in that first one individually, but I'm more concerned with the middle and third one there. Your extensor indicis, extensor digiti minimi, and basically your thumb motions, okay? So those are the middle and third ones. Don't worry about the top one. Middle and third one. I want you guys to understand that, okay? And there's a reason for that, because in a second you need to know why, okay? How are we on time? What time is it? 3? Okay, all right. All right, so this is what we saw earlier with the anterior compartment, just to kind of categorize things for you guys, superficial and deep. Okay, I want you guys to know which muscles in your posterior compartment, your dorsal compartment, are superficial, which ones are deep, okay? That makes sense? Make a box, something, go to this. Anybody have like a cool study place y'all go to now or no? Like, y'all stay here? So for a cool study place for this exam, probably the anatomy lab. Just get down there and have everything like strewn about, start learning these things, okay? You guys have any exams before mine or what? Physiology? And PD? Oh man. It is of the whole semester.
Well, we get the head to toe.
Oh, the head to toe. So I'm the last like multiple choice test.
Yeah. And we have physiology 2 days.
2 days before, and you have your lab quiz.
Yeah, the day before. Yeah.
You can do it. I did it. What's this called? Yeah. What's this? Extension. Circumduction? Yeah, there you go. All right. See? You won't forget now. All right, so brachioradialis, we kind of went over this. This is a big muscle right here. You can kind of see it when you're doing hammer curls. So the styloid process of your radius is right here. There's a little bump right there. You can feel it right there. So when you all do your hammer curl, he's literally contracting and pulling on that styloid process to lift your arm up this way, okay? So he's doing, what's this motion called? Elbow flexion, okay? And so he's contracting and pulling on that radial styloid, okay? Doing that motion. So think of yourself drinking water like this, or jugs of milk, whatever. And then basically it's doing flexion of the elbow, basically. Okay, so brachioradialis, where is he? He's right here. Okay, sorry, that big muscle right here. Okay, he's the first. I know if you brought that arm model to me at the lab, he's the one you take off. Remember when it comes off easiest? And yeah, that's him right there. So know where he is. This is good old Carl. He's got. Is that pink or red?
Pink
and red. Okay, so this is a good picture here. I would know that. Got arrows pointing directly at it. You can see where it's situated, how that works, like the hammer curls, where it's anchoring and then just basically causing that motion to occur. Okay. So here's your superficial group of your posterior compartment. So these are our little guys here. So these guys are all labeled here very nicely for you. So we got extensor digitorum pointing here. So as you can see, look, extensor digitorum, it's basically inserting at each of the digits. You see that? So it can create extension. Y'all got that? So you see the term there. Extensor carpi radialis brevis. He is brevis, meaning short, so he's right here. Extensor carpi radialis longus. He's longer. He's up here. Okay. See that? So brevis is shorter, longus is longer. Okay. Trying to help you guys out differentiate these. Your brachioradialis comes out of here, and it's the most superficial one right here. You actually like grab it if you're well developed right here. Okay. I should probably magnify glasses. Your Anconius is the little guy right here. He's adjacent to the triceps tendon. So this actual arm is like kind of like this, like look at me. That's how he's doing it. Okay. All right. And then look, so if something's facing more towards the ulnar side, it's going to be called extensor carpi ulnaris. So he's inserting right here at the ulnar side of the wrist. And then extensor indicis is for your index finger, okay? So literally knowing where these are, because like, look, you saw how the four tendons traverse into all the digits here in this picture. So now you'll understand that he's going to do extension of all those digits, okay? Extensor digiti and indicis are separate. So they create your USF bowl. How does it go, this little thing you guys do, the USF bowl thing? How does it go, like this? Do you guys do anything like that? No? It's just this? Okay. Yeah, so which one's this one? Extensor indicis, extensor digiti minimi, okay? Small finger. Mini digit is your small finger, okay? Pinky. Minimi. Does that make sense to you guys? Oh, yeah, sorry.
Sorry, do we have to know all four things for each, or should we focus on one more?
Wait, all those four things?
Like the origin, insertion, action, and evolution.
Yeah.
Promise.
Yeah. Yeah, because it's kind of like what I said already. The extensors come out of the epicondyle of the humerus.
Okay.
So you're already done with that. And then the insertion is the point where they're going to create the action on. So if your extensor indicis is coming out of there and the index finger, it's extending it. Okay. All right. Okay. So it's literally knowing your action. The forms is basically extensors come out of your lateral epicondyle, flexors come out of your medial epicondyle. Know specifically what each one is doing at the wrist. So listen up, guys. Wrist joint flexion, wrist joint extension, or digit extension or flexion. Okay, that's what we're focusing on. Okay, it's either going to occur at the PIP joint, DIP joint, or MCP joint. Your knuckles. Okay. And then you've got your pollicis, which is just anything doing with your thumb, okay? All right. Does that help you guys break it down? So the forearm muscles are going to create action at the wrist. These actions are going to be either wrist flexion wrist extension, digit extension or digit flexion. Okay, does that make sense? You just got to know your joints. Study your joints. MCP joint, PIP joint, DIP joint. Okay, because each one's going to create flexion or extension. Each one is, okay. All right. If you actually visualize where the tendons are located, like with Taylor, I was able to differentiate if she had severed her FDS or FDP tendons during the knife fight she was in. So we'll go from there. Okay. Yeah, we see it a lot where they come out with a knife, and then the defensive thing is to grab the knife, and it severs her hand. So, yeah. But you see how it makes sense though? Everything's coming off extensors, lateral epicondyle. Yes or no? So the flexors come off of which epicondyle? Medial epicondyle. Okay. All right. Let's take a break. And we'll come back and do more. Okay. 5 minutes. You guys need it. Go walk around. Do some jumping jacks. It's 3 days of AC. Question.
Like you actually
Suck. The best way of really getting in the lab. Yeah. I mean, great. Yeah, you have 2 dimensional this year, but we have stuff that you have to take apart. Yeah, I think last year they were they made files, like superficial muscles. This files, if they could come apart. Yeah, and I think that helped them too. I'm fine. There's a lot to it. But you're okay, like FDS, FTP, that makes sense now?
Yeah, that's making sense.
Okay. Yeah. Extensor indicis, extensor digitalis.
That's all
It's important that you're doing trauma and the hand is important to the job.
I think that's the one that we get. Oh, wait.
Yeah, it's just a lot. You're not muscle.
Yeah. Yeah, we have like a group chat.
Because it has them individually, so you can actually see them better. Yeah. Let me. I don't know. Do you have time for that? I mean, I'll do it faster. Yeah, it's on the same show. I think it'll have all single. It's just called Muscle. It's black and says Muscle. It's by a little movie top scary people. And there's, I think, the human heart, bloody head.
Okay.
Yeah.
Okay, right.
It's by Florence Kendall.
Wait, really?
Actually, no, I like
trying to make it easier for you guys. I don't know if I'm succeeding.
For like EC or no. Is it? I'm staring at those right here.
Yeah.
That's a surprise. I'm sure it was.
Yes, but there's like
Those are all connected.
We all looked at him, we're like, all right. In the last one,
All right, class. Okay. So Alexis here is going to be kind enough to help me out. So there's a textbook I have called Muscles. Sorry, called Muscles. Okay, I'll go first. So I've had this forever. It's called Muscles. Muscles. So it's about the cerebrum. But it's got little pictures and it's got pictures of isolated form muscles, okay, and their actions and how to test them. I think it'll help you guys out. Alexa's gonna take photos of each one and put on your, is it group chat?
Group me?
Group meet or
Me.
on the internet?
Me.
On the intranet, whatever. So I think that'll help you guys, because right now you see everything all grouped up together and it's panicking you guys, right? So I think if you have a page, a picture with the isolated muscle by itself with everything it does and how to test for it, I think that'll help it make it stick better, okay? I literally just remembered it while I was standing there. Like, oh my God, I have a book in my office called Muscles. So we could do that throughout for the other ones too, if you want, for like leg muscles, shoulder muscles. But for now, we'll do form, okay? I want to work Alexis here. She's busy, but she's being kind enough to help me out. Yeah, is that okay with you guys? That's cool. All right. Okay, so extensor digitorum. So notice here, its function is at the MCP joints, the knuckles. So right next to MCP joints, knuckles. Okay, so metacarpal phalangeal joints is what MCP stands for. Those are your knuckles, basically the ones you punch with. And that's where the action is occurring for the extensor digitorum muscle, okay? It also helps at the PIP joint, the next joint, okay? The proximal interphalangeal joint, so it extends there as well. So you'll be able to see that way better with the muscles book we're gonna be posting. Is that the term you use, posting? You know, I'm messing with you guys, right? I know what it means. It's like the act foolish sometimes. Extensor digitorum minimize, so basically it can extend your fifth finger or small finger, okay? All right, so pollicis means thumb. All right, so extensor pollicis brevis muscle, he's going to extend the thumb, so he's going to give you a thumbs up. So remember, is there a middle phalanx in the thumb? No. So basically this joint here is your metacarpal phalangeal joint. So this motion here is what your extensor pollicis brevis is doing. Extensor pollicis longus also does extension at the IP joint, okay? So brevis only does thumbs up here. Longus does thumbs up there as well, but also further up to the IP joint. So when you're pushing the elevator button with your thumb, that's your distal phalanx of your thumb, your interphalangeal joint of your thumb. So when that extension is happening and you're pushing, that's your EPL, they call it, okay? EPB just does thumbs up, okay, by itself at the MCP joint, okay? Abductor pollicis longus, so he's going to abduct the thumb at the more proximal joint down here, the basilar joint called the carpal metacarpal joint, okay, CMC joint. So watch my thumb. This abductor pollicis longus at the CMC joint right here. Trapezium, remember him? Carpal metacarpal. I got him fall. Extensor pollicis longus is basically doing thumbs up and interphalangeal joints. You can push that elevator button. And then your extensor pollicis brevis is just giving you a thumbs up normal, okay? Without messing with the interphalangeal joint. Everybody see what I'm doing here? So thumbs up, EPB. I extend my distal part. Y'all saw that? That's my EPL. I'm pushing the elevator button, okay? So practice that today in your elevator. Take turns. There's only 2 elevators, so 64 students, 2 elevators. Y'all schedule it. Okay. All right. So does that help you guys out a bit? Okay. Supinator muscle. So he's going to basically create supination of the form. Notice here is kind of a dynamic still picture because it's literally wrapped around and the radius is the one that's slowly moving over the ulna. Y'all see that? So that's what's happening. So that supinator muscle is basically pulling and rotating that radius, so it turns it to the anatomical position of anterior, okay? Supination. So proximal third is a term I'd rather use than upper third. So proximal third of the radius, origin, lateral epicondyle. Okay, so, and then we've done over the extensor indicis already. Overkill on that one. Surface anatomy. So this is your the palmaris longus tendon I had you guys look at and see if you guys have it. Everyone had that, right? Some people are missing. This was an expendable tendon. We use this a lot as a graft for surgeries. So you pretty much you can live without it. The muscles are just kind of fused by scarring into the rest of your forearm muscles. So, but yeah. Digit movement. I think we went over this already. Remember abduction, going away from the midline. There's a midline right down the long finger or middle finger. See that? This line right there. So you're moving away from that. That's abduction. Going away from it. Adduction, I'm going towards it. Extension at the, what are knuckles called? What joint? MCP. So I'm doing that. And an extension is return from flexion, okay? That's your extensor digitorum muscle, flexor digitorum muscle at the MCP joint, okay? And then PIP joint, the middle joint, flexion and extension, okay? These are actual hand exercises that I had to do for years, but yeah, this is a good one to help you understand the motions and the muscles and the joints, okay? Anatomical snuff box. So you see this picture right here? This one at the bottom, right here. I need you to know the borders of the snuff box, okay? Literally stare at this while you're eating snacks, enjoying your favorite beverage at the Wawa. Extensor pollicis longus is up here. You got your brevis as well as that. So those three tendons I need you to know on that diagram, okay? This is important because you're going to be there. This is the first compartment of your wrist. A lot of people get a condition called Dequer-Vane's tenosynovitis, and you need to decipher how to get a corticosteroid injection into the tendon sheath of that first compartment. And if you stick it in the wrong spot, you have problems. Okay, this is why it's important. I want you guys to know this. Okay, very common condition, seen in primary care, seen everywhere. Okay, so the snuff box, obviously, you got these structures in there. Scaphoid is in there, radial artery, but these tendons, the tendon borders, is what I'm really concerned with. Because you'll have to, I mean, this is great that you see it here in this dissected or degloved part of the person's skin, but surface anatomy-wise, you need to palpate this area. They have pain in that area. You need to know which tendon you're injecting it into and what motion has occurred. Because most of the time we put Marcaine mixed with the corticosteroid injection, so you're going to numb a part. Marcaine lasts many, many hours. So if you hit the wrong tendon, the wrong area, and but I'm still able to do thumb extension. Oh crap! I just injected the wrong tendon sheath. See what I'm saying? The importance of this. So you know this. This is not me just being, your undergrad anatomy professor. Know this. It makes the name sense. This is sport. Okay, it's functional. You're gonna see this a lot. Okay. And how do you test for Dequer-Vane's tenosynovitis? Finkelstein's test. You put your thumb in between, grab here, and then do this, and that'll create a stretching effect on the first compartment, causing a lot of pain for the person, okay? You obviously stabilize it with your other hands, but that's why I'm showing it's a very common thing. We type a lot now in this world. It's a very common thing that gets angry and irritated, okay? So big one there, know what it is, clinical significance. So obviously, yeah, if you have pain in the anatomic snuff box, you're going to suspect a scaphoid fracture. It could lead to numerous things, as I mentioned earlier, a necrosis of the bone. So also surface anatomy here. So the base of the thumb right here, this meaty part of your thumb, that's called thenar eminence, okay? I want you guys to know this because you have to be able to identify this when you're evaluating a person's hands. They have defect or atrophy in the thenar eminence. You need to notate that. Just ulnar to that is your hypothenar eminence, okay? Hypothenar eminence is here on the ulnar side. Thenar eminence is on the radial side of the thumb, okay? Obviously, you know, we already discussed what intrinsic muscles are, the ones in the hand, inside the hand that act in the hand, and extrinsic muscles are forms that are outside the hand but act on the hand, okay? But thenar eminence and hypothenar eminence, I'd recommend you know what it's composed of and what it looks like here on this diagram, okay? See that? What hand is that? Is that a right hand or left hand? Do you think it's severed? It's a really clean cut right here. Very skilled surgeon there. It's a joke, come on. All right, hand muscles. So, what time is it? 4:05. It's Friday, right?
Yeah.
That's credit here. All right. Yeah.
Thank you.
You're welcome.
I don't think it's that. Have a good day. Yeah. Because I like to draw. Yeah, right away. Yeah, my brother. What's the search for this? Great. I want to go right now. But I feel like it's more focused on like the action. I don't know. Most super artists or something like
Get that represents 10.5 seconds. That's a long time.
Yeah.
So that's why what I'm teaching guys is stuff that you guys have picked up on that. I'm not like BSing or teaching stuff just to know. I'm focusing on stuff that you see. It's typing nowadays, so more of stuff and this stuff.
But I know my wrist already. There's too much advice.
It's just
There's just too much that you need. Yeah, I put a picture of them. I know, like, there's no way. No, there's, but yeah, so that's, another semester too. Pretty much. When she goes to class, I do
I think having the
yes, I think that'll be for sure.
That way you guys can take the quiz and like stay there and study.
Yeah, exactly. No, I think that'll help a lot.
But I gotta change some between this third exam and this one. They could quiz like a week or 10 days after.
Yeah.
I gotta talk to Captain like that. It's just strange for me.
Yeah.
Not even students.
It's
I
a
had to
little,
look
like,
at that stuff.
It kind of just throws you off a little
Yeah.
bit. Yeah.
That's on the pelvis and reproductive stuff.
Yeah.
So I don't know what happened. It was
Yeah.
I don't know if it was because of the schedule or something. But it made such a quick turnaround. It was like 6 days between tests, 2 tests.
I know. Yeah.
So I'll talk to them this and I was like, you gotta do something like that. That was really strange.
Yeah.
It was strange
Yeah.
for me. I didn't students.
Yeah, it just feels like weird.
Yeah. So I'll address that.
I was gonna mention, I don't know if you realize on the quiz, you made it out of 0 points instead of out of 100 points for the
So
quiz.
which one was it?
I think, yeah, the most recent quiz for quiz 3.
Missed the third digit something.
Yeah, because I think it affected everyone's grade, like everyone's grade shot up. So, because it's like out of 0 instead of out of 100. So, I mean, well, I just wanted to let you know, because I
Yeah,
didn't want
I
to,
noticed on one of them, someone got 100 and I put 10 on it.
Yeah.
I thought it's fixed it.
yeah. When I checked earlier, I mean, well, when I checked
Well,
yesterday,
if it's
like,
like, is it like super boosting your grade?
Oh, like the final grade.
Yeah.
so like, I think it affects the final grade, because I think like, so I ended up getting,
Okay.
Oh, yeah.
Yeah,
So
do you see
it
what I'm
has it
saying?
as like
Yeah.
90 out of 0, so it's
Yeah.
helping my grade out a
yeah,
little bit more than it should
So I
probably.
gotta go back and redesign the action.
Yeah. So
Okay.
here, I'll show you. So like the quiz, this is what I got on the quiz, and it's out of 0 points. So that just means it like the average is gonna shoot up a lot. Like so, like it should.
So it should be on.
So it should be out of 100 points. Yeah.
Okay, so yeah, so I said I can figure it.
Yeah.
When I made it, I didn't do it like
Mhm.
that.
Yeah, because quiz 1 and quiz 2 are out of 100 points. So I wanted to let you know.
Thank
Yeah,
you.
yeah. Cause like it was nice, but I like felt bad. I was like, no, like I had to say something.
Because I really don't know how to do that.
Yeah.
2 weeks ago.
Yeah.
They're like, yeah, just put it in. I'm like, how do you do that? I'm not gonna do it.
Yeah. Yeah.
And the orientation was like one thing. Like, okay, focus on teaching. I'm like, okay.
Yeah.
Well, because everything else grades itself too, like the tests. So.
But
Yeah.
this is like, putting like paper quiz into
Yeah.
the system and then we got to talk that.
I wish there was something like on our tablets or on like our phones. Like,
Yeah.
I know it's probably like not the best, but like something where we can just like,
I wonder if
so you don't have to do that.
lockdown browser could be used and it was just, but then it would have to be, there has to be a way where you can, I think you can type in answers for tests
Yeah.
instead
I
of,
think Kaplan was kind of like,
That makes more sense.
they have to switch to, we're switching to something different called a film saw.
Oh, instead of
I don't know what
lockdown.
the hell it is.
Yeah.
I don't care. I'm just trying to make it this year. Apparently it'll allow you all to use your iPads to do the quizzes.
Oh, that'd be
Instead of a
nice.
piece of paper.
Yeah, that's so much better.
And it'll just be whatever, protected and all that
Yeah,
nonsense.
yeah.
And we upload the answer sheet and you go station 1, you do your choice.
Yeah.
Yeah, that'd be nice.
And then it's uploaded and graded, so
Yeah.
you don't have the human error like me.
Well, it just takes time out of your day.
Exactly,
And,
yeah.
Yeah.
Yeah, luckily I was able to finish all the grading the quiz day.
Mhm.
I was getting a little panicky the first 2 quizzes.
Yeah.
Oh my god, it was like game up. I gotta finish on this schedule. And, so I just gotta, so I just gotta reconfigure the points on the
Mhm.
quiz.
Yeah.
No, thanks for my attention, because I did notice when I finished something was screwed that
Yeah.
I couldn't understand. Like, what the hell was this happening?
Mhm. Yeah.
Thank you. Thank you for being honest.
You have a great rest of your weekend.
yeah, during the weekend.
Take care.
Cheers, all. Don't strike too much.
Yeah.
Take breaks.
Oh, for sure. We'll try to take breaks. Practice my punching.
Yes. I hope that helps. You understand.
Thank you. I've been practicing on my boyfriend, don't worry.
All right, and we're on. So I have some great news for you. We're not going to be learning intrinsic hand muscles, okay? It's just way too much stuff going on right now with everything, and I'm just going to do you all solid, okay? So the only thing you know is hypothenar eminence and thenar eminence. Know where those are located on your surface anatomy. It's pretty much all these intrinsic muscles you see here. It's a lot of minutia, a lot of fine motor tuning control motion. So the percentages of those getting injured are very low, okay? And as a PA, for us dealing with that, we'll probably refer something that happens in this area to a hand surgeon, correct? Yeah, so does that make sense to you guys?
Yes.
Or I could have you guys learn them. So. No? Sure. Okay. All right, so opponents basically means opposition. So this is opposition. You take the thumb and you take the little journey through your whole hand. Everybody do some opposition. Let's go 1, 2. That's opposition, okay? Abduction, adduction, radial deviation. So know all your motions of the wrist and your MCP, PIP, DIP joints. Is there a PIP joint in the thumb? What's it called? IP joint, yes, interphalangeal, okay? All right, so, yeah, hypothenar, just know them, don't know the muscles, just know the region on your hand, okay? Same thing here. This is what the hand looks like. Same thing here. These guys are in between the metacarpals. So this is just definitions of the what occurs at each joint with the muscles. But since I'm not going to have you learn these right now, so go from there. So this is some more motions that we just discussed. So the forearm muscles are actually extrinsic muscles that act upon the wrist and hand. Okay, so that's what I'm concerned with. All those forearm muscles, they act on the hand. Everybody know what I mean by extrinsic? They're outside of the territory they work on. So they work remote, basically. If you want to think of it that way. So that's basically what we're doing there. Here's some clinical scenario to help you understand this better. So tenosynovitis is basically inflammatory response of the tendon sheath that surrounds each tendon. They can get infected. This is called a horseshoe abscess right here. It'll continue to fill in over here. Okay. It'll really fill in here and then encompass these two metacarpal heads and create like a letter U, like a horseshoe. That's what's called a horseshoe abscess. Those need to be drained and IV'd in the OR. So, common in IV drug abusers and unkempt personnel. So, Dupuytren's contractures. Have you all heard of this before? So this is a genetic hereditary issue. You have a certain gene that doesn't allow yourself to lay down collagen nice and easy. So you have these thick cords in your hands and your feet that literally like deform your hands and create lots of spastic states. I know a friend of mine who owns a gym and he has to every morning put beeswax on his hands and use a stainless steel instrument to literally ease his hands up so he can train and do his job. So there's medication. I'm not really going to do much. It's still smart. So I've done a bunch of surgeries with this, and it's not pleasant either. Well, sorry, because you literally have to do like 9 or 10 small incisions, and then we debride all that scar tissue out. And they're literally like it was a bunch of nylon closures, and the guys like this for like almost 2 weeks. It works for a while, and in a few years it'll start to come back. So. It's pretty much one of those things that is not pleasant at all, and so it's bad. So we have your radial and ulnar artery. Know these where they're located. Obviously, that's where you take your pulse, right? Radial artery. So the other one's the other side. the radial artery. So that's what I would know for this. Don't worry about the arterial supply in the hand. That's intrinsic. Allen test. That's something you learn in PD class. It's just basically press down both of them. You see anything if it comes back or not. And obviously radial, the nerves, radial ulnar median nerve distribution, musculocutaneous nerve, axillary nerve. Those are ones I'll need. Okay, so. Oh, radial ulnar median nerve distribution. That's in the hand, basically. So whenever you evaluate the hand, you need to dictate in your note or type in your note. I evaluated the radial ulnar median nerve distribution, and you can state sensory function and motor function. Also, musculocutaneous axillary nerve is also part of the brachial plexus. Okay, all right. Any questions so far on that? Okay, sounds good. Yes.
How would somebody present with the ulnar nerve?
So they'll have numbness and tingling down the fifth finger and down the medial compartment here. So along. So we got, remember, C6 dermatome, C7, and C8. So numbness and tingling down the C8 dermatome. And they'll have weakness with flexion, extension, grip strength is going to be weak. Because remember, when we had to do the experiment with the tumblers, I didn't let you guys grip with the fourth and fifth. I let you guys just keep it straight. So that grip strength is going to be this adds, I think it's like 40% of your grip strength, the fourth and fifth metacarpal joints. So by gripping, it gives you strength, and they won't have that. It'll be a huge deficit. So it's either due to an ulnar nerve entrapment up here, where they have to do an ulnar nerve transposition, or they do an elliptical incision, and they take the ulnar nerve out of the ulnar notch and put it over here somewhere, so it's no longer getting impinged. So yeah. Okay. Yes, you had a question?
Just so I'm understanding correctly, like the APL muscle, the EPL muscle, that, like read it and understand it, but that's not, or is that?
Those are primarily for the anatomic borders for the snuff box. Okay. I need you to know those. Okay. So just know what they look like on a diagram, and that's a common finding you'll see out there, the wrist tendinitis, and I want you guys to really understand the actions, especially because if you inject cortisone the wrong one and they're doing thumb extension, hey, it's still angry, I don't know what's going on, and you injected the abductor follow so long as, that's practicality for me. So that's why. But yeah, know those borders on that one diagram I showed you guys for that, okay? And then be able to identify it as well on surface anatomy, okay? You got your little snuff box there. That's probably the only time I'll let you use that in a test, so just don't write on it. So yeah, you should know your borders just by staring at it here, okay? That's how you get it, all right? Okay, okay, let's take a 3-minute break.